This is a video demonstration of En-bloc Thulium fiber laser enucleation of prostate by Dr. Abhay Mahajan. This is a large prostate gland weighing 110 grams with typical trilobar enlargement. The lateral lobes are obstructive and there is large median lobe. The bladder is normal. The orifices are noted, which are very close to the median lobe. The incision typically begins on the left apical lobe of the prostate. The incision is deepened till the prostatic capsule is reached. And the left apical lobe is now lifted up away from the capsule. The dissection proceeds as far as possible from the base towards the 3 o'clock position. Once the left lobe is lifted up, then similar dissection is done on the right apical lobe. You can very well visualize the capsular fibers here. The apical lobe is now completely dissected off. The right side incision is similar on the apical lobe, just adjacent to the verumontanum till the prostatic capsule is reached. The right apical lobe is now dissected in a similar manner. Once this is done, both the incisions are then joined in front of the veru, keeping a small strip of mucosa in front of the veru to avoid any damage to the verumontanum. This incision is then deepened down till the capsule and it is extended on both ways to meet the apical lobe incisions. The floor of the prostate is then lifted as much as possible on both the sides and on the base of the prostate. Then a 12 o'clock incision is taken slightly proximal to the verumontanum. Initially the mucosa is incised and the incision is then extended on either side to join the incision which were previously done on the lateral aspect of the prostate. So this is the left incision starting from 12 o'clock position. This is the right incision, mucosal incision which joins the previous incision. So this is early apical mucosal release incisions which will further prevent traction on the sphincter and hence reduces the post-operative incidence of stress urinary incontinence. The roof incision is then deepened Then the next step is to start enucleation of the right apical lobe. The laser incision is at the junction of the adenoma and the prostatic capsule. The resectoscope beak lifts up the adenoma visualize the junction of the prostatic capsular fibers. This dissection is done all around from above downwards and from below upwards to join both the incisions and to enucleate the lobe uniformly. The laser settings are 2.5 joules and 22 Hz, a total of 55 watts for the incision, and for the hemostasis 0.4 joules and 50 Hz, that is 25 watts in total for achieving hemostasis. The right lobe of the prostate is now being enucleated. This incision is going above from 9 o'clock position to 12 o'clock position. And the right adenoma is now enucleated till it nears the bladder neck. Once this is done on the right side, similar dissection is done on the left side of the prostate. This is the left adenoma. You can see a small prostatic calculus there, suggests that we are at the capsule. The adenoma is now lifted up with a resectoscope beam. And the incision is taken exactly at the junction. The left prostatic lobe is now been lifted off and dissected off the capsule. The dissection now proceeds all around, if required, on both the sides, so that a circular incision is formed on the capsule. Once this is adequately dissected, then the roof incision is then deepened to open the bladder neck at 12 o'clock position. This is the roof. These are the fibers which are incised. Once you are at the bladder neck, you visualize the vertical fibers. If you incise the vertical fibers, you open the bladder neck. So these are the vertical fibers, which suggest that these are the bladder neck fibers. Once you incise that, you open the bladder. Then you take this incision on either sides downwards in a circular fashion to enucleate the gland. Now we are starting on the right lobe of the prostate. The bladder neck incision is taken down on the right side along the capsule. Once you open the bladder neck, you know where the capsule is. And you lift up the lobe as far as possible from the prostatic capsule. Similar dissection is done on the left side, inside the bladder neck from 12 o'clock downwards towards 3 o'clock, so that the adenoma is enucleated from above downwards. Once both the adenomas are enucleated from the lateral side, then what remains is only the floor of the prostate to be incised. At this point, the laser fiber is now turned from 12 o'clock to 6 o'clock position and the floor dissection is began. You have to hit towards the adenoma to prevent any trigonal perforation or trigonal dissection. A slight stretch on the adenoma is essential to avoid any bladder mucosal injury. This is the stalk or the pedicle of the prostate, which has been now incised from 4 o'clock position to 8 o'clock position. The lobe is now pushed in the bladder. The complete lobe is in the bladder so that you can visualize the pedicle nicely. Slight push with the laser guide will delineate the junction between the prostatic capsule and the adenoma. So this is the end of the enucleation. The complete lobe is now dropped in the bladder. You visualize the orifices to see whether there is an injury. Both the orifices are intact. This is one single lobe, including both the lateral lobes and a large medial lobe, which is now enucleated and and dropped in the bladder. This is the veru, a small strip of mucosa is kept. The lobe is again visualized and morcellation is then started. Morcellation is done with standard morcellation procedure. The bladder is well distended to avoid any mucosal injury. The blade has to be kept under vision at all the times. You can notice this minimal bleeding with thulium fiber laser, which aids the morcellation too. This is the end of the procedure. The bladder mucosa is again visualized. Thank you very much for watching.